Hello, everyone. This is Dr. Carrie Bedient with another episode of Fertility Docs Uncensored. I'm from the Fertility Center of Las Vegas, and I am joined by my two simply lovely, ravishing, mellifluously, yeah, that's the word, voiced co-host.
I don't know what that word means.
What is that? Define that for us.
It means just lovely and melodic voiced.
Ah,
Okay. Melodious, you mean?
No, mellifluous. Mellifluous.
mellifluous.
I can't get that right.
I've added a new word to my vocabulary.
Is that a Quirtle word?
No, that is more than five
Too many
letters.
Too many letters for that.
I'm joking.
It is more than five letters. I am outraged and offended that you would accuse Quirtle of breaking the rules. I was somewhere. Oh yeah, Susan Hudson from Texas Fertility Center and Eblen from Nashville Fertility Center. There you go.
Hey,
We broke the flow today. This is what happens when you introduce new vocabulary. We're like, halt.
Wait, we don't understand.
I can spell it. I can't say it, but I can spell it.
Well, spell it. Spell it for me.
Oh shit, you're calling me on it. Mellifluous. Mellifluous.
Wow.
That is a hard word to say. Mellifluous.
I'm impressed by that,
Yeah.
Carrie.
Yeah, like I know I'm in Vegas, but I have not been drinking this morning.
Well, you couldn't have said that word if you'd been drinking.
I don't know. I might have been able to get it out a little bit better. Like when I don't
off your tongue.
I don't drink more than like a glass of anything too terribly often, but when I do, all of my censorship completely drops away, and I just start talking, and I just go on and on and on, and so it will probably roll off my tongue a little bit easier.
I didn't want to bring that up, but I have experienced one or two times, at least once, when that happened. But we digress.
So what's new? What's going on?
Well, we were talking about our plans for the future. I was talking about my plans for the future. One of these days, I want to go to a bunch of different national parks. And, in Tennessee, we have Smoky Mountain National Park, but we don't have all that many on the east side of the country. And you were just telling me about Vegas, how it's a good stopping or good place to start from.
It's a good jumping point because you fly into Vegas, and within probably a 5 to 6 hour drive, you have the Grand Canyon, you have Joshua Tree National Monument, you have Bryce Canyon, you have Zion National Park.
Where's Joshua Tree?
It's in California.
Oh, okay.
Yeah,
okay.
It's the east side of California.
Okay.
You have Death Valley. You have there's another one that one of my friends just went to that they came back with gorgeous pictures that I don't remember the name of because it's one of the smaller ones.
Mm-hmm.
And it's just
how far away are you from the Arches?
That is, I don't know. I feel like everything is like 5 to 6 hours.
Wow.
Okay.
Yeah. And that's
where was the one you hiked in last year and it got dark and you were trying to find your way out? Was that close to where? Remember you were with the other group of people and you said you lost your way a little bit and oh well, never mind.
I don't remember that. Clearly it was traumatic enough that it totally
You were on vacation? It was last summer, I think.
Oh, that was Yosemite.
Okay.
That was Yosemite. That is further. That's like a
okay. You have to. Okay.
That's better to fly into Northern California and do, just because it's a haul.
Are you having PTSD now that I made you recall that to your frontal lobes?
Not in particular, mostly because the yelling that went on from the small humans in my life was remarkably similar to the yelling that went on this morning when I had the audacity to cut a waffle before I put syrup on the waffle. And so that's more just like the constant PTSD that I have. And so
okay.
There was no extra layer.
Not that big of a deal.
Yeah. Yeah.
Oh my goodness. Y'all are so funny.
Yeah. Do we have questions?
We do have questions. Okay. Our first one is, hi, huge fan of the podcast. I have a weight related question. I've always been a bit petite, 5'2", and weight hovers around 99 pounds. I feel like I eat well, plenty of plant-based protein, carbs, veggies, fruit, and exercise a healthy amount, walking dogs, occasional yoga. overall, my cycles seem regular. Could my weight be causing fertility related issues?
So
Cycles are regular?
Yes.
So I'm going to do a plug right now because I just scheduled 3 weight and nutrition guests to come on in the next couple of months here. And so
Nice.
tune in because we're talking about the weight loss drugs and we are talking about nutrition. And then there's, oh God, there was one other topic that we have all set that I'm waiting on the final word for that one. But tune in because we are all over this topic. But that said, yeah, possibly. Thyroid is oftentimes the first thing to go to give you kind of any sign that there's something going wrong, particularly when you have the lower caloric intake issues. Now, it sounds like you are, getting in a good amount, but the question is it enough for you and enough for what your body is putting out? Because sometimes people who say, oh, I eat healthy, they're the ones who the composition and the ratios of what they're eating is great. It's just not enough. And so particularly for a level of activity, like nutritionists are fabulous people to help with this because there's so many things that play into this that a lot of women are not eating enough for their body size. And that has an impact.
And 99 pounds at 5'2" is probably a little bit on the thin side. And
yeah, absolutely.
Though we don't have a whole lot of that necessarily, we definitely have more people who struggle with the opposite end. Definitely seen people who needed to be more cognizant of, like Carrie said, you sometimes just need more calories. I mean, you need good, healthy food to fill up those calories. But it's one of those things that not having enough body fat in your body is actually not good for building babies. And so there is a healthy balance.
Yeah, I was just going to suggest that too. I read something not too long ago about how cholesterol and fat for some people is important, even though you're of normal body weight and you ovulate regularly. That fat and cholesterol are building bone for estrogen and progesterone and all the hormones. And so, I don't know that there's a lot of data if you're having regular cycles that your weight, is the cause of fertility. But I think there's something to that. I noticed you eat plant-based protein, and that's probably fine. But see if you can get more like whole milk in your diet, more cheeses and things like that. And that may give you a little bit more cholesterol to help with, making estrogen and progesterone the hormones you need for pregnancy.
And cholesterol is important for building a pregnancy. And when we go in and do surgeries for miscarriages and we can actually see pregnancy tissue, it's yellow. And it's yellow because the building blocks of pregnancy is cholesterol. And that's one reason you can't take cholesterol medications while you're trying to conceive.
Mm-hmm. And it's not a hard and fast rule that if you follow a vegan diet that you have to come off of that in order to conceive. But I think all of us have definitely seen patients where once they did that, even temporarily, very lightly doing, whatever they found they needed to add back in, that it made huge improvements. So it's not like we're saying you cannot get pregnant with a vegan diet. It's just sometimes your body really does need that little extra help, especially if it's been running in a deficit for a while. It needs that extra little bit of loading up and priming all of the engines and getting everything set and ready to go. And so, nutritionists are super helpful in this.
More to come on that, right, Carrie?
More to come. Yes. Yes.
All right. One more question. Hi, love your podcast. I'm 39 with an AMH of 0.451. My IVF was canceled from a flare protocol. With DOR, what is the most aggressive protocol? My doctor suggested mini IVF, then said an antagonist protocol with estrogen patches and letrozole 300 Follistim 150 of Menopur. I also froze 2 eggs overseas in 2018. What are the chances of those eggs to survive the thaw? The canceled protocol, estrogen patches before the period, MD Lupron 5 mils 2 times a day throughout.
Microdose.
Oh, microdose. Okay. I was like, Clomid 100 for 5 days, Follistim 300, Menopur 150, day 2 FSH 5.4, E2 102, estradiol 54 on day 6, and 232 on day 10, follicles on day 10, She had 5 of them, a 10, a 7, and 3 small ones. So.
I mean, the problem is it's an individual. You said which one's the most aggressive? Well, some work for some people, some work for others. There's no hard and fast rule, but I will say for many, many years, the microdose Lupron flare protocol was the go-to protocol for people who were poor responders. And then I think probably 5 to 6 years ago, a lot of us evolved to doing a little bit of a different protocol. But, it's kind of unique to you. And it's kind of one of those things, unfortunately, it's trial and error. And, if if your estrogen level was 104, I think on day 5 after microdose Lupron, that's kind of low. That's pretty low. And unfortunately, if you just don't have enough good eggs for us to retrieve, it's not going to be helpful to continue. So kind of the answer to your question is, I think it's probably important for your doctor to look at what other protocols you may have done, if you have, and kind of look at everything and try and see if they can come up with sort of a different twist on that to see if it may be helpful. But in reality, it may be pretty tough to stimulate you with an AMH of 0.4.
So a couple of things. One, you were taking letrozole, so you need to take your estrogen levels with a huge grain of salt. Realize that letrozole can work really well
True,
in
yeah.
people who have diminished ovarian reserve in combination with the injectables and sometimes with Clomid. But the letrozole is going to artificially cut your estrogen levels. So it essentially makes them, we still watch them, but the true value of them, you have to take them with a big grain of salt. We use letrozole like in our breast cancer patients to keep their estrogen levels low. So take your estrogen level with a grain of salt. The other thing is, don't get hung up on what day of stim you're necessarily on. So used to say 10, 15 years ago, day of stim made a big difference because if you went beyond day 12, what would happen would be your progesterone levels would start rising and your endometrium would go through its conformational change and your implantation rates were going to suck. Okay. And now with a lot of
medical term.
Yes.
Got it. Okay.
And now, since we're doing freeze protocols, we don't necessarily have to base our decision making on, oh no, you're on day 10 and you haven't, your follicles aren't where they necessarily need to be. If they're growing, they can continue to grow because we really don't care what's happening to the endometrium, and we can make our decision just based on the follicles. So, that those are some things to kind of keep in mind. And just, I do agree with Abby. Some protocols work better with some people than others. And so I would just,
well, and remember this was a microdose Lupron flare protocol too. This wasn't just a like FSH 150. I mean, she was on a pretty hefty protocol and didn't respond particularly well.
Aggressive is all with respect to what the highest potential is. So aggressive in someone who is 28 years old with PCOS and a follicle count of 40 is very, very different than aggressive in someone who is, 42 with a follicle count of 3 and baseline high FSH levels. And so sometimes what we find that aggressive is less related to the medication doses and more related to how many times you go in to get eggs out. And so we know that we could hit you with every single medication in the book at super high doses, and it's not going to make a difference compared to Clomid, 100 milligrams, and that's it. And so with that in mind, you just kind of got to know that sometimes aggressive in this context is, okay, I am going to plan to do this multiple times in a row, back to back, with no intention of growing out to blast until I get further on, because I'm going to do a 2PN freeze because that consolidates some of the financials. Like we have different kind of specialty protocols for people where we're never going to get more than 1 or 2. And so all of a sudden the game changes, unless you are independently wealthy, from doing just 1 cycle where you get everything into doing like, okay, let us mentally plan. We are going to have to do 3 cycles, 6 cycles more. And we do it at a really low dose. We try and maximize the financial to your benefit all the way through so that you can get through that many cycles just in order to have a shot at having enough eggs at work. And so aggressive is not just with respect to meds. There's other things to consider too. And it's all in the context of what your max potential is. And so someone who's got 2 eggs, I'm never going to expect to get 10 out of that, but if I can do it 5 times, maybe I'll get 10 out of that.
Right. And in regards to your 2 eggs that you froze 5 years ago, I would almost use those in conjunction with another stimulation. So you're
Yeah.
maximizing
Fertilize them at the same time.
your embryology costs. And so get those in and take advantage of those, because heck yeah, I mean, I'd rather have eggs 5 years ago from everybody.
Yeah, that's true.
Absolutely. Okay, so today what we are going to talk about is how that initial consultation goes. And I think all three of us have had the experience of, you have a patient come in and you say, okay, well, let's get testing. And she goes, oh no, I already did everything with my OBGYN. And that means something different depending on where you are sitting. Just like a medication protocol means something different depending on where you're starting. What I've had all the testing means depending on who you had that done with. And so this is not slamming any other part of our profession in any way. It's just there are very real differences between them.
I want to interject before we get started. And one thing that we do want you to understand is some OB-GYNs are going to do some part of a fertility evaluation and some OB-GYNs are not. Both are okay. They are both very reasonable parts
Absolutely.
of the practice. The important thing to know is if your OB-GYN feels comfortable with it and they have an interest and all those kinds of good things, they're going to do a little bit more. If it's really not what's in their wheelhouse, they're going to refer you to somebody like us who this is what we live and breathe every day. So it's fine no matter which way your OB-GYN works. And neither one is a reason not necessarily to go back to them after you're pregnant. Okay. But they all have their strengths.
Well, and I'll say, interject here, one of the helpful things is, I agree with Susan 100%, because some people just don't like fertility. They like delivering babies or they like doing surgery. And they're like, there's a physician that refers and she goes, I just want to give it to you because I don't know any of that stuff. I don't want to deal with any of that stuff. And other people love doing the workup, and that's great. But whichever type of doctor you have, particularly if you have the one that likes to do the workup, it's really, really helpful if you make sure that they've sent your records and call and check and make sure that we've gotten your records before you show up, because we all feel frustrated, including, our patients and us, when they're like, but they said they were going to send all this information. I can't believe you don't have it, and so it's really helpful if you know for sure that they sent it, or that you bring it yourself to the visit yourself so that we have it.
And realize when you request that information, most states give an office up to 30 days to send that information. So if you call up the office and it's 2 days before your appointment, we're probably not going to get it. So just be prepared and understand that there's a process for that.
And also know that chaos goblins live in office fax machines.
Yes.
And we have all had the experience of our staff member on the line with the other office's staff member actively putting through whatever it needs to be and it not going through. And so it is nothing against the intelligence or skill of anybody's office staff. There are deliberate medical office chaos goblins that live in fax machines, whether it's digital or the old school, whatever. And they're very good at what they do, which is not doing anything. So I have another tiny little side note, because Susan, every time you and I both say this, it cracks me up. I grew up in training with OB-GYN or gynae. And every time, Susan, you say it, it's OB-GYN. And that makes me think of a little fizzy drink with cute garnishes on it. So Abby, remind me how you say
OBGYN.
OBGYN. Okay, so all three of us are different. All right.
Yeah. I never realized that we all three do it differently. Who knows?
It's all regional. So what are the basic differences between the levels of providers that you might see if you are going to an OB's office or an REI office? So let's talk about the MDs involved here, or DOs. Or
APRNs.
Or APRNs. We're gonna
we should probably break down what those letters all mean.
Yeah.
We should.
Okay. So first of all, what is MD and DO? What does that signify?
Medical doctor and doctor of osteopathy. Is that right?
Yeah.
Yeah.
Mm-hmm. So these are both groups of individuals who attended medical school, okay, and became physicians and then went on to do further training in OB-GYN as a residency. And that's a 4-year training program.
Okay, I was just about to ask that. What does medical school mean? Because sometimes I'll walk into an office and somebody will say, oh yeah, I went to medical school, and it means something very different to them than it does to me. Okay, so 4 years of medical school, that happened after what kind of preamble to get into medical school?
College.
Yep, with just a whole...
Studying really hard in college and trying to make really good grades so you could get in medical school.
So you get into medical school and you do your 4 years. Okay, what happens if you are a general OBGYN, which is what, kind of the name of the class of colleagues who they see everybody. And what they do is absolutely horrifying to me, because the thought of having to be responsible for the level of information and the breadth in particular, I think our general OBGYN colleagues are phenomenal, because I could not do that at all. I am way too OCD and would probably drive myself into a hole doing that. And I have a lot of respect for those who do it. So what training happens next once you graduate medical school?
So you go through residency, which is a 4-year program that you gradually gain experience and knowledge in a specific field. And in this specific field, it's OB-GYN. So women's health care, everything from obstetrics, delivering babies and prenatal care, to just regular everyday gynecology, pap smears, cancer, abnormal bleeding, just anything gynecologically related. And that is throughout a woman's entire life.
Now, when you're looking at OB-GYNs, gyns, GYNs, whomever, these people, generalists, let's do that. When you're looking at generalists versus REIs, what's the difference in training between those two groups of physicians?
So REIs have had additional training, usually 3 years, usually 2 years of research and 1 year of kind of active practice and learn how to do egg retrievals and taking care of infertility patients. And then basically at that point, they're able to go out and practice as a reproductive endocrinologist.
And what's the difference in the tests and the ongoing training between those two groups of physicians?
It's awful.
I would say, well, you're meaning tests like board certifications and things like this.
Yeah.
Okay. I'm just making sure I'm like reading the Carrie mind. So
what do you mean you can't read my mind automatically by now?
I know that.
I'm pretty good at it. I'm pretty good at it.
I was gonna say.
So as a general OB-GYN, you take a written board exam and you also do an oral board exam that you have to pass. Okay.
So 3 hours in front of 3 people.
Yeah.
With shooting questions at you right and left for 3 hours.
So that's for your general OB-GYN boards. And so most OB-GYNs are going to go through that process, as well as reproductive endocrinologists. Now, the REIs, the reproductive endocrinology and infertility specialists, are also going to do a whole additional set of written board exams and oral board exams to be double board certified in general OB-GYN and reproductive endocrinology.
Mm-hmm. And then as we're doing our maintenance of certification, or MOCs, so all physicians have to do that. What's the difference between the general OB-GYNs and the REIs with respect to that?
We have to do more.
Well, we have to, I don't think we have to do more. I think we just have to do REI. Like half of the questions that we do have to be REI, right? And then half of them have to be, they sort
we
of
have to do all the REI questions they give us and then fill in the rest with the general stuff.
Yeah.
And what that means is we read roughly, what does it amount to? About how many papers do we read a year? About
like 30, I think.
About 30, and about 15 of those papers are ones that our board has chosen as being really good papers that we need to know about, need to understand. So really top-notch research has been done. And so, if there's some really important study that's come out in the previous year, generally that's one of the articles that we have to read as part of our continuing medical education, which is really good. I mean, it's good for everybody, I think.
Yeah. And it's a little different than the general OB-GYNs, where they're reading the same number of articles, but theirs is spread over multiple sub-disciplines, like the oncology and the reconstructive surgery and the hormone and like all the things. So, okay. So that's the difference in training between an OBGYN and an RE. And those, in order to be either one of those, you have to have gone through 4 years of medical school, either as an MD or a DO. Now, there's other types of people that you may encounter in these offices as well. So PAs and APRNs. Now, what do those letters stand for?
physician assistant, or advanced practice registered nurse.
Yeah, and sometimes they'll go just by NPs. Sometimes you'll even see nurse midwives too. So there's kind of different, there may be different initials, but a lot of times that's their background is in nursing basically, as opposed to a PA that's actually gone to medical school for a couple of years.
Well, PA is so, and I don't know all of these details in super finite levels. So if you guys do, please chime in. So PAs, NPs, nurse midwives, they've all gone through college, right?
Yeah. Oh,
Yes.
absolutely.
Okay.
Yeah. Yeah.
And then
They all have bachelor's degrees, and then they
Yeah.
have usually, I believe, 2 years of classwork.
hmm
And then the remainder of their training is really on the job training.
Yeah.
So
I have some people who both have one that a PA and a nurse practitioner in the same family. So they were kind of comparing and contrasting. But from what I understand, PAs go to medical school, do 2 basic science years, but that's where they stop. And then it's more on the job training after that. Whereas nurse practitioners, it's like a master's in nursing essentially. And you can choose kind of what track you want to go on. There's a women's health nurse practitioner. If you want to deliver babies, you go on the track of a midwife. There's prison nursing, there's psychiatric nursing, there's kind of different tracks that you can choose. And most of the ones in our field are women's health nurse practitioners and sometimes family nurse practitioners too. So that's the other track that nurse practitioners can take.
And they can also get their PhD in as a nurse practitioner.
Yeah.
So the differences in some of these can be pretty substantial. And so it just depends on who you're seeing and what you're seeing them for as to how much that might make a difference, because the PAs and the nurse practitioners are oftentimes really fabulous. I mean, in the same percentages that your doctors are going to be fabulous and some are not. But there's a pretty substantial difference in the number of hours they have logged before they are even eligible to be able to do the on-the-job training. Like the REs are going to be at the high end of that because it's 15 years. It's 4 of college, 4 of med school, 4 of OBGYN residency, and 3 of fellowship, compared to the OBGYNs, which is 4 of college, 4 of med school, 4 of residency, compared to the advanced practice RNs or the PAs, where it's the 4 of college and then 2 or 3
Kind of like a master's program, basically.
Yeah. So there's some pretty marked differences in there. So it's helpful to know who you're seeing depending on the level of complexity that you have. And so that's kind of helpful to keep in mind. And so you can see potentially any of these people in any of the offices that you go into. So once you see them, let's say that you are walking into a general OBGYN office. And so at that point, you could be seeing a general OBGYN, PA, APRN. And you say, I've been trying to get pregnant for 12 months and 1 day, and it hasn't happened. And I'm 30 years old. And so fix it. What happens next?
So some people are going to refer you straight to an REI, like we just mentioned. Okay. And again, that is fine, but it's not the only option. If they want to do some of the evaluation, the things that they are most likely to do is to send you to get an HSG or hysterosalpingogram. This is an X-ray of your uterus and fallopian tubes while we inject some dye through the tubes to see if the tubes are open and healthy appearing. They sometimes may send your partner for a basic semen analysis, looking at things like count, motility, and shape. And occasionally they will do some labs. The most common labs that I see them do are an AMH level or anti-Mullerian hormone, which gives us more information on quantity of eggs as compared to quality, and often check your thyroid with a TSH level. Now, the important thing for you to understand about TSH levels. So people sometimes get a little confused on them. TSH stands for thyroid stimulating hormone. It's actually the hormone your brain produces that tells your thyroid what to do. So if your thyroid is not working well and your brain is having to work really hard to tell the thyroid to do its job, your TSH levels are going to be high, but that is in relationship to hypothyroidism or low thyroid hormone. So brain's working hard to get the thyroid to do what it's doing. So that's hypothyroidism. Whereas if your TSH level is super low, it's because your thyroid's screaming, and that would be hyperthyroidism or high thyroid hormone levels, both of which can cause some issues.
Okay. So let's say for a moment that you were to go straight to an RE's office. And so like Susan was saying, sometimes you'll come out of a general OBGYN office and they'll be like, no, just go see them because they don't want to deal with it. And that is a perfectly valid, response, as is a response of saying, oh yeah, let's get this testing going. If you walk into an RE's office, what tests are they going to order? And so let's think about it in terms of, you started with HSG. So that's a tubal evaluation. So if you walk into an RE's office, are they going to do tubal evaluation, first of all?
Yes, definitely.
And
but there's a couple of different options that they have. So a lot of times, sometimes we'll send patients for HSG tests for whatever reason, maybe cost, maybe closer to home, because we have patients that come from far away and sometimes they don't have easy access to our office. A lot of times we like to do a saline sonogram. It's a test where we put just saline or water up inside the uterine cavity. And it's really a better test to really look at the cavity. HSGs, if they're a perfect test and we have a perfect view, sometimes we'll be able to see if there's a big polyp or big fibroid, but more subtle things we don't pick up so much. So if we're really focused on the cavity, the saline sonogram is a better test. We can also put air bubbles through the fallopian tubes. And I would say, 95% of the time we can see the air bubbles. If we can't, sometimes we will send somebody for an HSG because that is probably a little bit easier test to see the tubes. But a lot of times we can kill two birds with one stone. And so for a lot of our patients, we really choose to do a saline sonogram because we can see subtle abnormalities. We can see if fibroids are close to the endometrium or close to where the baby would be, or if they're actually pushing into the cavity, which is bad. And so generally we recommend doing that, or I'd say most probably REIs would recommend that over an HSG.
So I do both for different reasons. I think that HSG gives me a better view of the fallopian tubes and helps me delineate like hydrosalpinx a little bit easier than
I agree. Yeah.
the bubbles. And so if I have somebody who I'm worried about tubes, I'll do the HSG. If I have somebody who I'm worried about the lining, if you have heavy bleeding, if you have irregular bleeding, which means you're not shedding your lining on a regular basis, those are people that I often will do a saline ultrasound. So I do both in a lot of people.
Yeah, as a side note to that too, when you said hydrosalpinx, it made me think, if you know that you've had pelvic inflammatory disease or some sort of pelvic infection, or have strong reason to believe that one of your tubes or both of your tubes are blocked, be sure and make sure that's discussed with your OBGYN. And because a lot of times we'll give you antibiotics to take ahead of time. There's a slightly higher risk than normal if you've had a pelvic infection. Somehow it can be kind of reactivated and you can get a pretty severe issue with infection in your tubes if if you're not prophylactic with antibiotics. And generally if you get antibiotics, it usually takes care of that. We don't really give it as a routine for everybody because we would probably be given way more antibiotics than need to be given. But if you've ever had a pelvic infection, be sure you share that with your OBGYN or your REI before you have that test.
So what tests, and this is something that can be done by OBGYNs or REIs. I think REIs are a little bit more likely to go to this a little bit sooner just by virtue of the patients that we see. But what are the surgical options for evaluating the uterus and the tubes?
So hysteroscopy and laparoscopy are the two types of surgeries that probably we do more commonly. Laparoscopy is where we make an incision in the belly button and probably 2 or 3 small 5 millimeter incisions in the lower abdomen. The purpose of that surgery is to be able to, or one of the reasons we do the surgery is to be able to look at the fallopian tubes, the uterus, the ovaries. We can evaluate for things like endometriosis. We can also evaluate and make sure that there's not damage to the fallopian tubes. And in some cases, we may try and fix that. Some cases, we may actually take the tube out if it's really too damaged to be repaired. The other procedure that we do is hysteroscopy. That's where we put a telescope up inside the uterine cavity. You're asleep for all this. And we can also do it at the same time that we're doing the laparoscopy surgery as well. But it's a way to look inside the cavity and also treat any problems that may be there, like get rid of fibroids if they're there, or polyps that they're there, and just make the cavity look more normal and more healthy for an embryo.
Yeah. And how can you evaluate the tubes during a laparoscopy?
We can inject some blue dye through the cervix into the uterus to be able to come out the fallopian tubes that we can actually see in real time during the laparoscopy, looking at your pelvis. So we can see if your tubes appear swollen or hydrosalpinx. We can make sure that they are open. We can tell if the fimbria, the little ends of the fallopian tube, look nice and filmy and feathery, which is what they're supposed to look like, or if they look clubbed, like the end of like if it looks like a fist versus being feathery and more like your fingers.
Okay, so to compare and contrast, general OBGYNs are typically have reasonable access to HSGs and ordering that. They have the ability to do the laparoscopies and the hysteroscopies for surgical evaluation. A lot of them don't automatically jump to that just because if they're getting that far, a lot of times they'll send to us. Looking at the uterine evaluation, some OBs can do the saline sonograms, others don't have as easy access to ordering that. Like, they can do it, they don't have the stuff to do it as easily.
And the timing is difficult too, because it has to be timed at the
Exactly.
right window
That's
of time.
actually a huge part of all of this, and that the
Yeah.
timing is important, and our offices are built for that. General OBGYNs are seeing everybody, and it's just technically
They can't get you in at the spur of the moment, basically. Yeah.
Exactly.
While we're talking about ultrasounds, oftentimes when you'll go into either your OB-GYN or your REI, you will get a pelvic ultrasound. A couple of things to note. So number one, this is not going to be the ultrasound on your belly. Okay. It is going to be a vaginal ultrasound, which means that we're going to use a long, narrow probe that has a condom and gel on it. And we're going to go take some good pictures of your uterus and your ovaries and take measurements.
And those condoms that we put in are special ultrasound cover condoms. We did not go to Walgreens and buy the Magnum because it was on sale. Like, this is intentional. There is no flavoring and there are no colors on this. It's just functional to be protective.
Exactly.
Which is, I guess, what a regular condom is too.
But an important thing to know is
maybe not in Vegas though.
If you have an ultrasound with your OB-GYN, there are certain things that they generally don't look at in as much detail as we do in your reproductive endocrinologist office. So a lot of times people will be like, oh, I already had my ultrasound done. Well, yes, you've had an ultrasound done, but there are things like looking at antral follicle count, looking for septums, bicornuate uterus, different things like that, abnormalities of the shape of the uterus that are not normally commented on those ultrasounds. So even though you've had one at your OB-GYN, please don't be surprised if your REI is like, I really need to see live images myself and do a little bit more in-depth looking than what you may have had beforehand.
Yeah. And on that same note, looking at pictures, a lot of times the pictures are really terrible. And unless you have your hand on the probe and you're looking around yourself, or your ultrasonographer does, it's really hard to see. And a great example of that happened to me just the other day. I had a patient who came in and had mentioned that she knew she had fibroids. And so she even read the report. Oh, I've got a 3 centimeter one and I've got a 4 centimeter one. And I thought, well, I said, well, I'd like to look again just to kind of see what we see. Well, we put the wand in and the probe in, and my ultrasonographer, who has 30 years of experience doing this every day, all day, she couldn't see anything because apparently there was a much larger fibroid there somewhere that was really shadowing everything else. So in that particular patient, we're actually going to get an MRI. And if I just looked at the report, I would have been like, oh, she didn't have very big fibroids. Everything's fine. And in reality, you really couldn't even see her endometrium, which is a really integral and important part of doing the vaginal probe ultrasound.
So it's that targeted experience that you're getting with specifically the fertility stuff that, even if it's not the doc themselves doing it, like our ultrasonographers in RE offices tend to be there for years to decades because they're good at what they do, and getting accurate egg counts, getting accurate anatomy, fibroids, knowing when the ectopic is there, seeing when it's a peritubal cyst versus an ovarian cyst, like all of those things make huge differences to us. And so we kind of drill them into our ultrasonographers, and they get really, really good at seeing those things. So
as you say, and that's very dependent on the person that does the ultrasound. And so I guess as Carrie was saying, we have really well-trained people that do it. And it's not everybody that does a vaginal probe ultrasound does it equally. It's really a skill, a difficult skill that people acquire over years and years.
Yeah. So talking about the egg evaluation. So we've talked about ultrasounds and the differences between them that you might get in each of those respective offices. The AMH level, or anti-Mullerian hormone, that we order, that is not time dependent. So that is easily ordered by whichever office. What is the third component of egg testing that we will sometimes order?
Day 3 labs. So estrogen, FSH, and LH.
Right. Now, can you get this in both types of offices?
You can, but again, your OB-GYN's office, I don't want to say that they're, as you mentioned, they're doing so many things that when you call with your period, they're not set up to be like, oh, we need to do your day 3 labs, where this is like we work on everybody's period. So
we have to,
period,
we have to work on everybody.
Like,
yeah.
it's this beautiful cycle that everybody's going through on their periods. And so we just have it set up. And so, oftentimes when we get FSH and estradiols, they aren't necessarily correctly timed. So it's something that we have to be aware of. So, it's not that you can't get it with your OB-GYN, but just make sure it should be on cycle day 1, 2, 3, 4 at the latest. And sometimes we'll see people who get the labs mid-cycle, towards their end of the cycle. And yes, that gives us some information, but it's not the information we're really aiming to get.
Yeah, because the FSH hormone is really time dependent. It's a big difference if you do a day 3 lab versus day 7 or 8 lab, because that's when FSH is starting to go up. And high is bad if we see it on day 2 or 3, but if we see it on day 7 or 8 or 9, not so bad.
It's normal.
Yeah, it's normal.
Yeah. And sometimes it's pure luck of the literal draw of, you happen to be in your OBGYN's office on day 2, 3, 4, and they were able to get it and nail the timing, or you happen to be able to get the lab appointment for the right day. But a lot of times it's just not logistically possible.
Yeah.
Let's talk about the male half of testing. And
Okay,
so
before we hop to males, there's another group of people that I want to talk about are people who are not ovulating on a regular basis. Okay. That's a group that I see a big difference in what OB-GYNs order versus what you come to see in REI. So in my practice, I often see if they're having irregular periods, they'll often get, like we talked about the AMH level, they'll probably get their thyroid checked. They may get a prolactin level. Prolactin level is a hormone secreted by your brain that normally makes you get breast milk after you have babies, but it can be a little off and it can make your periods a little irregular. And so sometimes OB-GYNs may order that. As a reproductive endocrinologist, our evaluation for somebody that we're concerned about having PCOS, or polycystic ovarian syndrome, is more in depth. There are things. There are other hormones that we're going to look at, things like 17-hydroxyprogesterone. We're going to check something called DHEAS, which is a hormone secreted by your adrenal gland. We'll often check your lipids because we know that, or your cholesterol levels, because people with PCOS do tend to have more elevated cholesterol levels, even if they are normal weight. We're also going to be checking your blood sugar, either with a blood glucose level or a hemoglobin A1C, which shows us kind of the average blood sugar over the past 3 months. So we're generally going to do more testing than what you may have already had.
Cool. All right, switching over to the guys. Do OBGYNs like to treat men?
No,
they did not. They did not go into it for all of that. And so some of them will order some of the basic semen analysis testing. Others of them will say, have your male partner go get his stuff evaluated, or just go see the RE. As opposed to the REs, where we don't have a singular patient. We oftentimes have couples, because it's the unit, whatever the unit may be, that has that. And so that brings up the other component of that, which is that a lot of our patients don't have a partner. They have a partner of the same sex. And so we know that there's automatic stuff that we are going to have to provide that they don't have easy, ready access to, whether that's donor sperm, donor eggs, a gestational carrier to carry the pregnancy, all of those things. And so we are totally set up to do that. Whereas most OBGYNs just don't have that capacity because it's such a subspecialized part of what we do that it's not reasonable to expect them to have that capacity.
Well, one thing to say about the sperm count too, Carrie, and you may be getting to this, but I've noticed we have like 7 states that are around Tennessee. So we have a lot of people that come from different places. And a lot of times, or at least some of those places, particularly that are pretty far away, their doctors a lot of times will order a sperm test. And a lot of times they send them to the local hospital, and the collection room's like right off the waiting room, and they don't give them any parameters or tell them when they should collect or how long they should abstain for. And sometimes, and this doesn't happen everywhere, but I'm over exaggerating a little bit, but sometimes it can sit there for a while, and we know there's a time constraint on when we should look at the sperm. And so lots of the outline sperm tests that we get are not quite as accurate as they really should be. And so there's a time frame. We don't want them to sit for very long. We want to get them within 45 minutes to an hour and be able to look at them within that time frame. We want the male partner to ejaculate somewhere between 2 to 5 days. We don't want them to wait longer to ejaculate or ejaculate too soon because the numbers are thrown off. And some of the outline labs that we deal with too use WHO, World Health Organization standards from 20 years ago. And I'm not exaggerating. I just saw a patient 2 days ago, and this has been a known problem for years with these certain hospitals that still use the wrong criteria. So I had a guy that had a sperm count of 50 million, which was a great sperm count, and he thought it was low. And the WHO standards have changed because we know that men can actually be fertile with a much lower sperm concentration. And so that's the other thing to look at. So generally, when you come to our office, we'll want to have you repeat it again in kind of a standard way so that we really know if there's a sperm issue or not, basically.
Another difference that you'll see from the male perspective is that we may do additional testing on men more than just the plain old semen analysis. Additional testing could include things like sperm QT, looking at genes that are held within the sperm that can be turned on or off abnormally. And these genes determine how well a sperm can bind to penetrate and actually fertilize the egg. Some of us may do some testing looking at something called DNA fragmentation, and sometimes we'll even do blood work, looking at hormone levels that can contribute to, abnormal sperm production. And while we're talking about sperm production, I'm just going to get on my soapbox for just a minute. Guys, do not start testosterone. Oh my goodness, do not start testosterone. If you have low testosterone levels and you need something, go to a urologist. Make sure they know that you have plans of creating a family in the future and get the appropriate treatment. Sometimes that is testosterone with other things at the same time, but understand that if you take testosterone in any way, shape, or form, injections, pellets, creams, pills, whatever it is, it can actually shut down the communication between your brain and your testes. And sometimes we can't reawaken it. Okay. So it's very real. Like, we understand you want to have good, strong testosterone levels and it makes you feel great, but we also want to make sure we have swimmers. So.
And that's the one thing when you see a patient and they've written that down that they take testosterone, there's the good and the bad. The bad is we think the sperm is going to be low or non-existent. A lot of times the good news is once you stop it after 3, 4, or 5 months, the sperm numbers will come back to whatever their baseline was. And we hope that baseline is normal.
But
not always. That's
not
right.
Always. Not always. All right. Cool beans. Well, this has been a jam-packed episode. And to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe. Leave us a review in Apple Podcasts. We appreciate that. Say hello on Instagram. Say hello on Facebook. Like us and follow us and say hi.
You can also visit us on fertility.suncensored.com to submit specific questions. All questions will be answered on our Ask the Doc segment. Even leave us episode ideas or other ideas. We really love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right. We'll talk to you soon. Bye.
Bye.
Bye.